Okay, you guys, we are going to talk about the child with neurological dysfunction. All right, I'm going to talk about nursing assessment of neurological dysfunction just kind of as a whole. We'll throw in some representative conditions. Some of the things that we could see if the child has neurological dysfunction going on: tense, bulging fontanelles, irritability, high-pitched cry, increased head circumference, headache, nausea, vomiting, blurred vision, seizures, restlessness, drowsiness, decline in school performance, weight loss, or memory loss. There are a few other things that we can also assess for. Obviously, more of our neurological assessment: altered level of consciousness, alteration in pupil size and reactivity, diminished physical activity and motor performance, and inability to follow simple commands. Head injury is one of our first representative conditions here, and head injuries are on page 1365. The different types of head injuries we could see in kids: concussion, closed head injury versus open head injury, a contusion, intracranial hematoma, epidural, subdural, intraventricular hematomas. Fractures, we could see a linear fracture, a depressed fracture compound, basal, all different types of skull fractures. Diagnostics that we typically use are a CT of the head or brain, and then there could be some possible surgical intervention. Causes of head injuries could be a birth injury, child abuse, motor vehicle accident, bikes, falls are the leading cause of head injury. Concussion is the most common. Confusion and amnesia are the hallmarks of a concussion. The child's response to a head injury differs a lot from an adult. If you think about kids, think about what they look like, especially the younger the kid. They've got that big old head sitting on top of this little body. So they got this large head and this body that has insufficient musculoskeletal support. So it makes them more vulnerable. That's why little kids are so clumsy, okay? And then don't forget the surface area of the scalp. Again, the younger the child, the larger that surface area is. And the younger they are, the scalp is extremely vascular. So the younger the kid, if they get a simple laceration on their scalp, they could bleed to death from that because it's so vascular. So make sure you're keeping that in mind. All right, so those were our head injuries. Nursing care. Again, obviously the nursing care, this is just kind of some general nursing care, depending on if it was a concussion, if it's a contusion, if it's a skull fracture, might add in some things, take some things out. But this is kind of our general nursing care for head injuries. We want to make sure we're maintaining a patent airway. We need suction when needed. Maintain stability of the head and neck and the spine. Elevate the head of the bed 30 degrees. Frequent neurological assessments and report any changes. We want to monitor for any CSF leaks from the nose or ears. Again, cerebral spinal fluid is clear and it is colorless, but anything that's leaking, we monitor for it. If we test it and we see that it has glucose, that would suggest that it is cerebral spinal fluid. Maintain fluid management. We already talked a million times about how important fluids are in kids. Possible urinary catheterization, nutrition. We could administer an osmotic diuretic. We could give an anti-epileptic, anti-seizure medication. Again, we want a calm environment, decrease stimuli, prevent complications, provide support. Nursing care continued. Assess Q2 hours through the night, especially with a head injury. LOC, they could be on bed rest. Initiate seizure precautions. Watch for subtle changes in their behavior, and make sure you're listening to parents about any behavior changes. Parents typically know their kids best, and we need to listen to them when they have any serious concerns. All right, brain tumors are next, and brain tumors are going to be back on page 1314. Let me get there. All right, so you will see brain tumors on 1314. We have some different types of brain tumors. We have an astrocytoma. This is the most common. Oh, I forgot to move my slide here. Sorry, let me keep going. Okay. Brain tumors, astrocytomas, most common, can be low or high grade. Low grade has the best survival rate at around 75 to 85%. We could have a medulloblastoma, 20 to 25% of pediatric tumors are this. They are fast growing, highly malignant, but they do have a pretty good survival rate at 70%. We are seeing a decline in this, in an incidence of these type of brain tumors due to prenatal vitamins. We have an ependyoma, that's 4% of peds tumors. It invades the ventricles and it obstructs CSF flow. When I start telling you obstruction of CSF flow, hopefully you're going back to that increased intracranial pressure content. The survival rate for this is 45%. There is gliomas, that's 15% of peds tumors. It does invade the brainstem. It's highly resistant to therapy. And that sentence right there should tell you that these kids have a poor survival with that. When it comes to survival, prognosis will depend on the type of tumor, tumor size, and the extent of the disease and the child's age. We talked about how prenatal vitamins are helping decrease the incidence. Your brain tumor assessment, headache, vomiting unrelated to eating, those are the most common. You could see behavioral changes, staring, spells, loss of previously attained developmental skills, and you'll also see a decrease in school performance. Loss of motor control, ataxia, weakness. We could see any of those signs and symptoms related to increased intracranial pressure. Again, don't forget we found that information on page 1356. They could have diplopia or double vision, seizures, changes in vital signs, and LOC. Some of the different diagnostics that we could do is a CT scan, MRI, tissue biopsy, cerebral angiogram, lumbar puncture. Our nursing care is, first and foremost, we want to prevent injury, side rails up, floors free of clutter, seizure precautions, make sure we have airway protection items at the bedside, an artificial oral airway, suction, oxygen. We want to keep the child oriented to reality, make sure you're calling them by their name, touching them before you talk to them, describe their surroundings, describe all the treatments and all the care that you are providing to them. We would, again, with a brain tumor, we could see chemotherapy, radiation, and we could possibly be preparing them for surgical removal of the tumor to decrease increased intracranial pressure and prevent sensory alterations. I'm going to give you some information on bacterial meningitis because I think that's the next thing on your slide. I'll stop after that because then we've got a case study that goes along with this. Okay, bacterial meningitis should be on page 1372. Assessment data would be an abrupt onset. Initial sign may be a seizure following an episode of an upper respiratory infection or otitis media. So the kids have been sick with some sort of upper respiratory otitis media infection, and then they could have seizures after that. We could also see chills, fever, vomiting, neck pain, stiffness or rigidity in the neck, headache, irritability, high-pitched cry, photophobia, poor suck, apnea. We could see altered LOC, delirium, stupor, increased intracranial pressure, bulging, fontanelle, hyperactive reflexes. They could have severe hyperextension in their, that's when their head and their heels both arch backwards. Some different diagnostic tests we will do for bacterial meningitis is a lumbar puncture to obtain cerebral spinal fluid. We would see an increase in protein in that cerebral spinal fluid. We could also culture them for H. influenza, E. coli, streptococcal. Your nursing diagnosis or our issues that we're managing here with bacterial meningitis: risk for infection related to communicability of meningitis, risk for injury related to CNS irritability and seizures, altered nutrition less than body requirements related to fever and poor oral intake, and then knowledge deficit regarding prevention of the disease. Okay, and all of my other issues on the next few slides will be covered in the case study.